Okay, so welcome everyone to our community joining us today for our first webinar of 2024. So our Global Tracheostomy Collaborative webinars, we'd love to bring you education that is important to you and is prioritised by you as a learning need. So I'm Dr. Amy Freeman-Sanderson, and I'm delighted to be moderating this webinar today with my co-host, Dr. Vincia Pandian. So our topic today is safety and tracheostomy, understanding risks and optimizing care. So I would like to firstly just acknowledge and thank our sponsors for the unrestricted educational grants that support our mission and vision at the GTC of creating multidisciplinary teams of physicians, nurses, respiratory therapists, speech pathologists, and most importantly, patients and their families and many other health professionals working together to disseminate best practices and improve outcomes with regarding tracheostomy care. I would like to acknowledge the traditional custodians of the land that I'm on. So I'm joining you from Gadigal land, and that's in the Eora Nation in Sydney, Australia. So I pay my respects to the elders past, present and emerging, acknowledging them as the traditional custodians of knowledge for this land. We're delighted that this webinar reaches all parts of the globe, so please feel free to pop in where you're joining us from today into the chat. So our key objectives today across our three panelists include these. So it's understanding the immediate and short-term safety risks associated with tracheostomy placement. We've got outlining best practice for assessment of stoma and surrounding skin. So some particular information and education around that. Recognizing the steps to optimizing safety with a tracheostomy, and that's across different areas, whether it's in the hospital or community. And understanding how families navigate this safety in daily life. So we're really fortunate to have a fantastic panel of experts across the globe. So just very briefly, Associate Professor Stephen Warrillo, Christina Keppel, and Nicole Kavite-Zeitler. And you'll hear more about those speakers in the introductions in a moment. The agenda for today, so we will hear from these three panelists, and then we'll have our Q&A section at the end. So that's an opportunity for the speakers to come on as a panel. And I would encourage you to use your Q&A function in the, on your Zoom links. Please pop your questions there, and we will sort of try and answer those and bring them to the panel. Anything that doesn't get asked, we will make sure we follow up. So please use that Q&A function to post your questions. So at this point, I'd like to hand over to Dr. Vincia Pandian.
Thank you, Amy. Amy does such an amazing job behind the scene, identifying speakers, prepping them, and ensuring all the logistics are taken care of. So I do want to thank you, especially on behalf of the president of Global Tracheostomy Collaborative, Dr. Michael Brenner. Thank you, Amy. I also want to give a quick shout out to our executive director, Marissa Snell, and her team for all the promotional technical work they've been doing in the background to ensure that these webinars are successful. And so I hope that each one of you are eager to see the fruits of their hard labor, since everyone has planned a very important topic that focuses on safety in the context of tracheostomy care. As many of you know, tracheostomy procedures are life-saving interventions that significantly impact the lives of patients and their caregivers. However, they also introduce unique challenges and risks that necessitate attention to safety measures. The implications of overlooking safety in tracheostomy care can be profound, affecting not only the physical well-being, but also the quality of life of the individuals. Sometimes can even be life-threatening. And so to learn safer tracheostomy care, join me in welcoming our first speaker, Professor Stephen Warrillo, who's an intensivist and director of intensive care at Austin Health in Melbourne, Australia. He's also the divisional director of medical services at the same institution and director of the Critical Care Institute at Epworth Healthcare. His expertise also extends to academia, where he holds an appointment with the University of Melbourne He's a former examiner with the College of Intensive Care Medicine and currently serves as a senior examiner for the Royal Australasian College of Physicians. As past president of the Australian and New Zealand Intensive Care Society, he has made significant contributions to critical care practice. He's been involved with Global Tracheostomy Collaborative since its inception and played a key role in organizing the 2019 World Congress of Intensive Care in Melbourne. I was there, I attended the conference, I remember it very well. Professor Warlow's professional interests include critical care tracheostomy care, clinical governance, end-of-life care, clinical teaching, and complex communications. So please join me in welcoming Professor Warlow, whose expertise will enrich our discussion on tracheostomy safety through the lens of a physician.
Thank you so much, Vincia, for your kind introduction. I've got a couple of declarations just to share. We can go straight. Thank you very much. So I live and work on the lands of the Wurundjeri people. I pay them my respects, particularly to their acknowledging their culture and their leaders. And as Vincia has said, I've got a number of associations run professionally here in Melbourne. So I'll just make a perhaps obvious but really important statement that it should be okay for our patients and their families to assume that we as healthcare professionals have the intention and the ability to safely care for them. And I think we'd all acknowledge that patients with a tracheostomy are often at the apex of both complexity, but also potentially vulnerability. Our patients and clients with tracheostomy have unique characteristics that mean that they may be more vulnerable to a range of complications. Also, nearly all of our care is delivered by a range of complex processes, and they require a range of people across various craft groups and disciplines to get everything right. And when things do go wrong or a preventable complication occurs, it's almost always because there's a problem at multiple levels. And those of us involved in tracheostomy care, and particularly families, will have seen that things do go wrong. It's a tough space to work in. So the next three slides are in some ways the least important part of the presentation, but they're very necessary just to acknowledge the sorts of things that can go wrong. I won't be going into exhaustive detail about all of the different complications because many in this forum will be familiar with those. But breaking it down, during insertion, there's a range of things that can occur from a technical procedure of the tracheostomy tube insertion, and those are listed there. And notably, they're pretty similar across different techniques, be they a surgical approach or a percutaneous type approach. Similarly, early on, for a person that has a tracheostomy, there's a range of other complications that can occur and various risks. Those are listed there, particularly bleeding, which is not necessarily a serious problem, although it sometimes clearly can be. More commonly, things such as tube obstruction, localized infection, positioning issues related to the tube, or at worst case scenario, accidental decannulation are things that can crop up. And then there's the late complications. And again, those are very familiar to healthcare workers, but also for people who live with a tracheostomy and those that care for them. So another important truth I'd like to share is that in my last 25 years of professional practice, every single healthcare worker that I've ever worked with has come to work every day intending to do the very best for their patients. And I think that's a useful thing to reflect upon, that we work with great people that do really their level best on every occasion with every encounter to try and give the patient the best possible outcome and experience. It's also important to reflect upon that healthcare is a risky business. As we've already commented on, many of our patients have unique vulnerabilities and considerable complexity. And I'd venture to suggest that those of us in acute healthcare have seen that increase exponentially over even the time that I've been in practice. The types of care provided on wards now is dramatically more complex than it was when I was a junior doctor. And these risks occur in a psychosocial context. And there are things that can be protective, which we'll touch upon shortly, and things that can exacerbate the risk. Issues that can exacerbate risk include less than ideal leadership, can make risks worse, insufficient training, guidelines, or opportunity to practice, having a very steep gradient of hierarchy where it doesn't feel safe to escalate concerns, a poor culture where individuals feel blamed if there's a problem, or there's a lack of overarching team-based care or a lack of team identity, or where there's evidence of clinical instability, where just people fundamentally aren't very nice to one another in the workplace. And things like rudeness or poor communication absolutely contribute to risk for our patients. And finally, perhaps the most important consideration that increases risk is if we fail to involve patients and families in decisions affecting them. That will absolutely increase risk. So we've talked about the bad things, but what are the good things that can be protective regarding risk? Well, certainly optimizing teaching, training, simulation is important. Having guidelines that are relevant, accessible, and easy to use. Having a situation where everyone understands their roles and works well in a team-based approach with shared and individual responsibilities. Having high-performance clinical leadership, well-developed quality assurance, governance type processes, a flat hierarchy that's really supportive and inclusive and makes it a safe space to express concerns and escalate issues. I've also included a research culture. There is actually really good evidence that in, say, an ICU or various specialty wards, having team members involved in research absolutely enhances the performance of that department and gives better patient outcomes and reduces risk. So I personally don't see research as separate to clinical practice. It is an essential part of clinical practice. And finally, and most obviously, a crucial protective factor is involving patients and their families in designing processes and implementing decisions that affect them. So going into some of these factors in a little bit more detail, a clinical governance program that works well is incredibly important. We've already touched upon having a safe reporting culture. One thing I've noticed in my own practice is that we spend a lot of time reviewing adverse outcomes where a patient has been actually affected, but less time on where we have had near misses. And I would venture to suggest that the near misses often teach us as much, if not more, than those incidents that actually gave an actual poor outcome for a patient. They're harder to capture, but I think they're really important. Also, to acknowledge that safety is everybody's responsibility. And if the most junior member of the team cannot effectively escalate a concern, then there is a serious problem with that clinical culture. Obviously, regular reviews, reporting and benchmarking are essential. I think the GTC, since its inception, has done an enormously good job in providing the capability to undertake benchmarking that we never really had before. And as I've touched upon earlier, clinical research absolutely has an important contribution to patient safety and reduction of risk. And when we do these things well, as it turns out, people notice. One of the most profound insights that I've ever had was from a patient's relative, where their loved one in our ICU wasn't actually doing very well, but we were trying our level best to support them. And this patient's wife said to me, I knew, and she used his name, I won't, but I knew my loved one would be well cared for when I saw how well you cared for one another. So I think when we do these things well, it is very impactful for patients and their families. So how do we get this right? Well, as has already been outlined in the introduction, safety is absolutely everybody's business. So how does that actually look when we try and implement it? Well, we've got to get the foundations right. And as I've mentioned several times before, we must involve patients and their families and their carers, and then not only ask them, but actually listen to their answers. What is their experience? What worries them? What keeps the parent awake at night who's caring for a child with a tracheostomy? What does a patient with, say, with a spinal cord injury, what's their experience of receiving care? And also, what do they think could work better? None of us will have the monopoly on solutions here, and the best outcomes will be genuinely derived when we ask the people that we look after how we can best provide their care needs. I'll also give a plug for the multidisciplinary team. And there's some of our key leaders in the tracheostomy space, the tram space at the Austin. Prue Gregson is our team leader, and every person in that team is a high-performing expert. And the real strength comes, however, not from their individual capability and expertise, but from the unified power of them working as an effective team. It's also essential to get the paperwork right. You must have really well-developed policies, guidelines, standardized training, and a simulation program. The good news is you don't have to start this work from scratch. There is some excellent work that has been done over the last 25 years at a range of centres of excellence. And again, I'll give a plug for what happens here at the Austin, my institution, through the TRAMS team. But there are other resources there. Many of them are accessible through the GTC website, which I've given a little screenshot there. So you don't have to start from scratch if your organisation is a bit behind in this space. Using these as inspiration can give you a flying head start. As I've said, find out what's already there. Engage with your own local experts and bedside clinicians, and then adapt the best documents you can find, ensuring that they are relevant to your clinical practice and geographical location and resourcing. I would strongly recommend that they are made as simple as possible, that they are relatable to everyone that's going to be providing the tracheostomy care, and that they're understood by those people. You then need to promote the guideline, ensure that there is a standardized approach, and make it accessible. And I think current IT technology makes this sort of thing a lot easier if you have effective search functionality. This is an example of some of the documentation that we've developed here at the Austin. And there was a lot of input from a range of experts, from anesthesia, intensive care, trams, respiratory medicine. We had physiotherapists, specialist nurses, occupational therapists, speech and language therapists. Everyone had some input into this. Now, it's not an easy process because the more people you involve, the more complicated the input is. And someone has to finally put this all together. But we emphasize that these documents need to be succinct, relevant, and readable at a glance during a crisis. And we made it very clear we've got a separate, if anyone's taking interest in these, we have a separate one for laryngectomy patients. And that's for primary responders. The next one, which you'll see, is one for advanced responders. So the first one is for potentially an inexperienced junior doctor or a bedside nurse with limited tracheostomy experience. And then we have an advanced responder approach for example, anaesthetists who might have very advanced airway skills, obviously, but less familiarity perhaps with tracheostomy care. And again, this one is for tracheostomized patients. We have a different one for laryngectomy patients. Important to reflect on the essential requirements for effective teaching, training, and education. Some of these elements will be, of course, discipline specific, but a lot work best when they're team-based. We provide all of our care really as teams, and our responses to risk really work best when we apply the same principles. And I think tracheostomy care is a great example of where simulation can be extremely helpful. Just a plug for getting your equipment right. I have fallen for this trap as well, where I've got a really favorite toy or a favorite video laryngoscope, and I insist that it needs to be in the kit. The problem is so does everybody else. And you end up with a difficult airway trolley or a tracheostomy emergency kit that has 3,000,001 different devices in it. And in a crisis, that is entirely unhelpful. So I would strongly recommend keeping things as standardized as you can, limit what's on your response kit, and only let it be as complicated as it needs to be. We've already touched upon clinical governance, quality and safety review and audit. Again, I'd emphasize report your near misses and evaluate them just as thoroughly as your actual poor outcomes. have safety huddles, have an MDT review, a multidisciplinary team review of all adverse events. Benchmarking is now increasingly possible through work undertaken by the GTC, and make sure that we provide feedback to families and patients. In my own jurisdiction, that is a legislated requirement that I adhere to statutory duty of candour requirements, where not only is it a good idea and the right thing to do, but I have a legal obligation in my jurisdiction here in Victoria, Australia, to actually do that. I've already touched upon research, so I won't spend a lot more time on that, but just to emphasise what I hope I've made fairly obvious, I passionately believe that research is an essential part of clinical practice and patient safety. And ensure that you've got a great safety culture. Just like the rules of the road are important, that we have to stop at red lights, we must stop at stop signs, we need to give way signs, we need to adhere to the speed limit. Those are all very important rules of the road, but without clinical civility, respect for one another, and a great team-based culture that people feel positive about coming to work and enjoy interacting with their colleagues, then the rules of the road on their own will not guarantee effective patient safety. It's essential that anyone can escalate a problem or concern, and additionally that we obviously empower patients and families to be active participants in their own care. The platinum rule applies, which is wherever possible, we should try and treat people the way they wish to be treated, not just the way we like to be treated. And in healthcare, I think, particularly acute healthcare, we should always expect the best, but be prepared for the possibility of the worst. And also to relentlessly encourage our colleagues, particularly our junior colleagues, if in doubt, escalate, and that it's safe to do so. Thank you.
Thank you so much, Stephen, for your enlightening talk, sharing how healthcare is a risky business, even though every healthcare professional comes to work with intentions to do the best they can. I loved your Swiss cheese analogy, which serves as a powerful framework for understanding the complexities of safety in healthcare and highlights the importance of a systematic approach to risk management and quality improvement. I agree with you that safety is everybody's responsibility, and it's also so very important to not just care about best practices, but you really highlighted the importance of listening and also giving feedback to both patients and family members to be able to provide the best quality of care. Thank you, Stephen. So it is now my pleasure to introduce our second speaker, Christina Keppel from Medical College of Wisconsin at Children's Wisconsin in Milwaukee. Her journey in pediatric otolaryngology as a nurse practitioner began in 2005 when she received her Master's of Nursing from Marquette University. She later received her doctorate in nursing practice in 2010, further solidifying her commitment to advancing patient care and clinical expertise. She has been involved in their hospital's multidisciplinary tracheostomy and ventilator programs, one of the nurse practitioners since 2005. Beyond her professional achievements, she's a mother of 3 active children. In her rare moments of rest from demanding profession, she talks about cheering from the bleachers at baseball games and attending soccer tournaments. She really cherishes precious times with her children and family. Today, I believe Christina is unable to join us in person, but she has sent her recordings sharing her invaluable insights and experiences in stoma care, offering a unique perspective from her years of dedicated service as a nurse practitioner.
So thank you for having me. My name is Christina Keppel. I'm one of the nurse
I'll just reshare that.
practitioners at Children's Wisconsin in Milwaukee, Wisconsin. I work through the Department of Otolaryngology
Sorry, folks, I'll just try one more time.
I don't think it's playing, Amy. It's frozen.
It's not playing.
Just hit play.
Or ear, nose, and throat.
Very good.
And I'm also one of the nurse practitioners on the multidisciplinary trach vent clinic. So skincare for our patients with trachs is extremely important because at some point in every child's journey with their tracheostomy, they will experience some type of skin issue needing our attention or the family's attention at home. The three most common skin issues that we'll see are granulation tissue, moisture breakdown or ulcerations, and yeast infections or questions of potential yeast infection. So granulation or tracheal granulomas are by far the most common reasons for consultation or inquiry. Granulation tissue is formed during that proliferative stage of inflammation, which results in polypoid vascularized tissue, which ends up being raised often above the stoma. In addition to just simply having a foreign body that's present in an airway that's not supposed to be there, the cited causes that can contribute to granuloma formation are bacterial infection, reflux, suture material, or the just mechanical force or friction from having the trach there. Oftentimes it can be pulled on by the ventilator tubing and can cause granulomas in that area. So we don't always treat all granulation tissue. Some patients have very small and non-interfering granulomas, which can be present for months or even a year. And as long as that granulation tissue does not interfere or cause any issues, you can actually let it go and monitor. There are a few patients who have such a reactive airway with that trach just being there that if we went after every granuloma, we'd be treating them for almost 90% of the year. There are some granulomas, though, which are more concerning than others, and we should or do intervene when the granuloma is larger and interfering with trach changes, if that granulation tissue is bleeding or weeping and it just doesn't resolve, or if they have circumferential granuloma, in which there would be a concern or risk of further stricture of that stoma. So because granulation tissue is an inflammatory tissue, medical treatments with steroid components are often used to shrink this tissue. One of the most well-established treatments that we utilize is triamcinolone, or commonly called Kenalog cream, and we will typically use a 0.1% concentration cream. We'll have families apply that triamcinolone cream directly to the granulation tissue or the granuloma twice daily up to 14 days. If it's not inside the stoma, we'll have them use a medical grade cotton swab for application. Otherwise, a glove finger actually works quite nicely. We always say, stop the cream after 14 days because with prolonged use of any steroid cream, you're going to get a lot of tissue thinning and fragility, and you can end up with a little bit more problems than just the granuloma. It's really beneficial to use if you have a patient that does not have excessive secretions and you're not worried about bacterial contamination, because then that cream will be able to sit and absorb into that granuloma better. The second therapy that we use is ciprofloxacin, dexamethasone, otic suspension. This is an off-label use because, of course, this was manufactured for ears and not trachs. But I will mention it because it's so commonly used throughout many institutions now with kids. The reason we use it is granulomas can be exacerbated by bacterial contamination. And so the antibiotic component of Ciprodex or ciprofloxacin dexamethasone will actually provide that bacterial coverage, which may be exacerbating that granuloma. And then the steroid component will treat the granuloma. We'll have them, again, use 2 to 3 drops twice daily for up to 14 days to that area. And this is really helpful if you have, again, a patient with a lot of secretions, but also you can access a granuloma that might be extending into the stoma because you're going to be dropping a liquid onto the granuloma, and it can provide better coverage in this manner. And then finally, we have been utilizing silver impregnated foam dressings for very small granulation tissue formations or granulomas that we've seen in patients. Those that don't really require steroids or don't need a antibiotic drop to be utilized with them. The silver does have some antimicrobial properties and coverage, so this is beneficial. And it's nice because you can continuously use this silver impregnated dressing over several weeks to help provide coverage and shrink down the granulomas. And then in our institution, silver nitrate is not always our first line therapy. It's not our first line therapy because we have great medical therapies available. But we do utilize silver nitrate if we're having difficulty controlling granulomas that have already received medical therapy. So silver nitrate, the mechanism of action is it coagulates the cellular proteins to the outside of the cell and to form an eschar tissue. This essentially destroys the cell of the granulation tissue to stop the growth of the tissue. We want to be really, really cautious with silver nitrate because we don't want to be overly aggressive. We don't want to press too deeply, causing damage to the underlying surrounding tissue. And we worry that if the child has excess secretions, it can carry this chemical around the skin and cause cutaneous burns, chemical burns. So to prevent the chemical burns of the surrounding tissue and skin, we'll be very careful to absorb any excess secretions prior to cauterization. Then we cauterize the granuloma with silver nitrate, and after that, we'll blot that area to make sure that we can pick up any of the excess chemical to prevent it from weeping into the surrounding areas. We'll have families avoid the foam dressing for about 5 or 6 hours after the silver nitrate application because we don't want any of that excess chemical getting absorbed by the Mepilex or the foam dressing, spreading it over to the surrounding tissue, and then letting it sit on that tissue, causing the chemical burns. What happens with granulomas eventually is that they will progress to have a cutaneous or skin surface. So clinically, when you're looking at fibromas and when families are assessing the tracheostoma, they can be somewhat confusing because on first glance, many fibromas do appear to be granulomas due to that irregularity along the stomal rim. However, because there's a skin covering now and it's no longer exposed vascularized polypoid tissue, it's not going to be responsive to steroid treatment and it's not going to respond to cauterization. We don't worry about fibromas. If they're small and they're not interfering with trach changes, we let them go. Most of our patients will have some small fibromas present and we don't intervene. When we do intervene is if they're becoming larger and they're interfering with the trach changes, at which point we will need to surgically excise that fibroma and revise the stoma. So on to moisture irritation and moisture dermatitis. This is also a very frequently encountered issue, almost as frequently encountered as granulation tissue. We have patients with trachs and their kids, and they have lots of tracheal secretions, which contributes to a lot of moisture surrounding that stoma. Additionally, they're growing and they have wider necks with a lot more fat tissue than most adults will. And so you get a lot of rolls in the back of the neck. You have the ties there. It's going to harbor moisture. And then it can lead to skin breakdown and lead to this overall erythematous dermatitis or moisture dermatitis that children will have. We really want to address the moisture dermatitis, these red areas, the areas behind the skin ties, the areas around the stoma, because eventually we do not want this to lead to any skin breakdown. So our mainstay of treatment is really to provide a skin barrier in an ointment or a cream or a paste, which will prevent the moisture from penetrating into the skin. What we do want to look for is products that do not contain Vaseline or petroleum jelly, as those oils could potentially be flammable for our patients with oxygen needs. The most common of these barriers that we will see is Centicare, which is now Remedy Protect Skin Oxide, as the company was bought out. We also carry Sween cream, which a lot of institutions will. These are all zinc oxide creams. They go on real white and thick, but they will provide that moisture barrier for patients. It is not covered once patients are home under, at least in our area, under the DMEs. And so out-of-pocket costs for Centicare or Remedy Protect is about $10 to $15. The two products that are on the right-hand side, the middle and the right, are actually products were found by parents. The first of these products that a lot of families have been using is Burt's Bees. It's a multi-purpose healing ointment made of beeswax that provides a layer of moisturization and a barrier for water penetration. It's not covered by insurance. It may be covered by families' HSAs, and out-of-pocket cost is about $10 to $15 on Amazon. The second on the right-hand side is called Waxline. It's also a multi-purpose ointment and barrier ointment. One family in particular had tried at least like 5 or 6 creams and ointments, and this is the one they found luck with. And so this came into our periphery and our view after the family said, hey, we've been using this product and we love it, and it's cleared up the redness and it's cleared up the moisture dermatitis, and that patient's skin looked absolutely amazing. So what Waxline is it's a combination of beeswax, vitamin E, soybean oil, and rosemary oils. It's a little bit more expensive, also not covered by insurance, and it will run about $30 to $40 on Amazon, but this product will last for months. And so it depends on how much families are able to invest. And then also, well, we always have to mention foam dressings. Foam dressings will absorb moisture by wicking it off the surface. They can come in regular. You can have the light dressings, which are thinner in quality and can be put under the skin or the trach ties. And then silver impregnated foam dressings will have that silver embedded in there and provides an antimicrobial property, which can be beneficial for some families and some patients. So then, unfortunately, some of the moisture irritation does lead to ulcerations and breakdown of the skin and the surrounding stoma. So we would see from time to time some skin breakdown or some ulcerations in new trachs, postoperative trachs. And one thing that we did was change the practice to have the patients come back from the OR with a foam dressing. This has actually helped decrease our ulceration rate around the stoma in the immediate postoperative period. And we now actually rarely see any post-op ulcerations or skin breakdown of the trachs. For the other ulcerative areas not in that immediate postoperative course, there's several therapies we can use. We will often use foam dressings to provide a cushion and limit the friction. It can have the antimicrobial properties of the silver impregnated foam dressings. If you have a deeper ulceration, though, we can use a hydrogel sheet, and hydrogel is a complex hydrophilic polymer with a high 90% water content. It's great for hydrating those wounds, so those shallow ulcerations, as it provides a moist environment for cell migration. You can rehydrate the eschar tissue, and you can aid in the autolytic debridement. So we'll often use these dressings or these sheets in dry to mildly exudating ulcers, because if you have more of an exudative ulcer, we would want to use a alginate or hydrofiber dressing. Our institution utilizes the Aquacel Silver Advantage, silver hydrofiber dressing, and these are great because they can absorb 20 to 30 times their weight in liquid. And then finally, we have Meta Honey. Meta Honey is a medical grade active leptospirillum honey. It's it's produced from the bees collecting nectar from the leptospirillum species, a flowering plant, and it's sterilized by irradiation, which removes the botulism spores. It provides a moist environment. It has a lower pH, which inhibits bacterial growth. And it has some activity proven against MRSA. So that's also very helpful. So we'll utilize Meta Honey as a barrier or a treatment, and then provide a dressing over that, and then change that out every so often per need. So this is an example of the use of Meta Honey in a patient. This was a shallow ulceration of the neck. That we were able to utilize Meta Honey dressing changes, and then several weeks later actually ended up looking pretty good. So then also friction, we always tell families don't wash and reuse the ties because every time you wash and reuse the tie, it's going to kind of degrade that foam, and you're going to have more Velcro exposure to the back of the neck, leading to friction irritation. If you do get a lot of friction irritation, our #1 therapy is a foam dressing. And then finally, erythema from moisture is often misdiagnosed as a yeast infection. So years ago, the mainstay for all families of trachs was to routinely use nystatin powder. However, a lot of the patients with moisture erythema were clearing with the powder, and not because it was a yeast infection, but because the powder was drying up the liquid. However, a lot of patients with trachs do have yeast infections. There's a lot of moist environments. There's a lot of tracheal secretion. So what we're looking for with a yeast infection is an erythematous area, and you'll have satellite lesions or these little dots surrounding that area. It can be slightly raised as well if it's been there for a while. So our treatment is typically nystatin powder, cream twice daily for 14 days, and then just keeping that area dry. So this is my last slide, and I'll just offer a final note of the impact that my chart has had for families. The extent of skin breakdown and granulation tissue or moisture irritation is often difficult to explain via phone call, and we can either overestimate or underestimate its significance. But being able to take a photo and send it to our care team has been valuable in that it takes out that subjective, that need for that description out, and allows for a more virtual assessment. So it can be fast, it can be effective. It takes out the need for families to bring a very medically complex child in for assessment all the way, maybe sometimes even across town or an hour away, for an assessment that we can do in 10 seconds. It's not perfect, doesn't always work, and sometimes we do need the kids to come in, but it's been fantastic. So I just want to thank you for allowing me to participate in this forum and share some of our experience and tips and tricks that we've developed in skincare for our patients with tracheostomies. And the other thing I wanted to add is just to families, if you're listening, please just continue to share what's worked for you and what hasn't worked. For example, our barrier ointments that we recommend to families, families have told us about them. We've checked them out, we've made sure they were safe, and then we're able to recommend those treatments and those therapies to other families who have also benefited. So if you're a family listening, I just want to thank you for being our resource as well and our partners in care.
I want to thank Christina for diving deep into stoma care, because this is one aspect of tracheostomy care
Thank you
that
for having me. My name is Christina.
Truly stumps many clinicians, because you occasionally end up with these granulomas that just refuse to heal. And what works for one individual may not work for another. So I really appreciate her sharing so many different considerations in the management of granulation tissue around the stoma. It is now my privilege to introduce our third speaker, Nicole Kovide-Zeitler. Nicole's journey is one of dedication and advocacy, both in her personal and professional life. As a mother of 2 children, Nicole's life took an extraordinary turn when her son, Pierce, was born. He entered the world facing complex medical needs, which led him to receiving a tracheostomy at just 6 weeks of age in January 2014. Since then, Nicole and her husband, Ben, have been the primary caregivers for Pierce's tracheostomy, navigating the challenges and responsibilities that come with alongside with their typically developing daughter. Despite the demands of caring for Pierce's medical needs, Nicole also dedicates herself to her professional role as a trial attorney in the disability rights section of the Civil Rights Division of the United States Department of Justice. In this capacity, she champions the rights of individuals with disabilities, including children like Pierce, ensuring they have access to the necessary support and services to thrive in their homes and communities. Her work enforcing Title II of the Americans with Disabilities Act is instrumental in shaping policies that promote inclusivity and accessibility for all. Her tireless advocacy extends beyond her family's journey, impacting the lives of countless individuals with disabilities across the nation. So today, Nicole brings her wealth of personal and professional experience to our discussion on tracheostomy safety, offering invaluable insights into the realities faced by families like hers and the importance of ensuring adequate support and resources for individuals with complex medical needs. So please join me in welcoming Nicole Kovide-Zeitler, whose dedication inspires all of us.
Thank you, Vincia. Thank you for inviting me to be here today. I'll be speaking from my perspective as a mother of a child with a tracheostomy in the American healthcare system. So for those of you in other countries or those of you who work with only adults, I hope that at least some of this will be transferable. So this panel is about safety. What does safety mean for trach families? For families of typically developing non-trach children, that usually means staying safe usually means avoiding dangerous situations, but that does not apply for trach families. Trach families cannot avoid dangerous situations. If your family member has complex medical needs, such that they have an open airway, they are constantly in danger Our family members are at increased risk of life-threatening illness and also risk of suffocation. So for trach families, safety with a tracheostomy really means preparedness. How can trach families prepare to handle dangerous situations? It starts with good transition planning and good discharge planning. And you, if you are a medical professional, no one should be leaving a hospital with a trach or with a family member with a tracheostomy without having preparation for what they will encounter on the outside of the hospital. Hospitals do have discharge planning, but in my experience and in the experience of some of my peers, hospital discharge planning can be insufficient if it's too disconnected from what families will really need to be able to handle what they will face at home. Families must be connected to appropriate support services to prevent and deal with crises at home. And they must be provided information on what kinds of emergencies they could encounter outside of the hospital, because you can't prepare for something you have no information about. Families must have a workable plan for dealing with emergencies, and you can help get them information to create a workable plan. The plan will change over time, but any plan is better than no plan. So let's talk about support services. Why do we care about support services? For so many reasons, but as it relates to safety, support services really equals crisis prevention. Families must be connected with appropriate support services before they leave the hospital. And this is where you come in. Families who are brand new to tracheostomy care and maybe brand new to disability just don't know what they don't know. They don't know that they would be eligible for state-funded health insurance. In the States, it's Medicaid. And in many states in America, children who have nursing facility level of care needs, who are children with tracheostomies, are eligible for Medicaid based on their care needs and regardless of their parents' income. But many families don't know this. They could also be wholly unaware of their eligibility for private duty nursing and why they would need that. They don't know about durable medical equipment and why they might need 2 suctions or 2 ventilators. You know that. The concept of 24-hour awake and alert caregiving and what it really looks like at home is just foreign to people whose children or other family members who have typically developing needs. Don't underestimate a new parent's inability to see the arc of their newborn care needs. I remember getting home after bringing my child home from the hospital, from the NICU. He was still an infant, and someone had done the application for me to get me a permanent disability placard on my car. And I remember looking at it and thinking, I don't know why I need this. My child isn't disabled. He's just having a hard time breathing. I could not see the arc of my child's disability and the true complexity of his medical care needs, but that's because I was trying to survive in the day that I was in. So information is everyone's job. Don't assume someone else has connected the family that you're sitting in front of to services. If the family's in front of you, please ask them and tell them about it. Families need information about emergencies outside of the hospital. Good practical information about life at home with a tracheostomy is hard to find. When my family discharged from the hospital, we were taught to do all the cares for my son's tracheostomy at the bedside, which was important and critical. But I got almost no information on how to live with my floppy newborn who had, a connection to a pulse ox from his toe and a connection to a heavy oxygen tank from his neck. And so because I didn't get any information about that, because I'd only been taught how to deal with holding him next to a hospital bed, anything I had to do, even just figuring out how to walk around my house, not being tied to the nursery, was terrifying. But it doesn't have to be, because you know what kinds of things your patients will want to do when they leave the hospital. They're going to have questions like, how do I drive with my trach child in the back? They're going to get in the car. It's just not something that they've done before with someone with a tracheostomy. How do I give my child a real bath with a tracheostomy? I suspect that many people who work in hospitals who teach parents to bathe their child in the bed expect that we will be doing that going forward at home. And that's just not that's not generally what we do. We want to put our kids in a bath. And there are things you can buy easily on Amazon and at the grocery store to help you bathe a child safely, even until they turn 3 years old. I had my child in a particular plastic bathtub that was big enough. I didn't learn about that from the hospital staff. I learned about it from other parents. How do I go to the grocery store with a baby on a vent? It is a daunting, terrifying idea to someone who has never been outside of a hospital with all of their medical equipment. But it's easily ascertainable by just talking to parents. There's even less information about what kinds of emergencies families might experience outside of the hospital. And I think this is best illustrated by looking at the example of new parenthood. Entering parenthood for the first time can be scary and overwhelming, even if you have just a typically developing newborn. But there's an entire industry of consultants whose job it is to prepare parents of typically developing children. You can take a 6-week course on what to do when your baby arrives. There are full sections in libraries about what to do with your newborn and how to care for typically developing babies and children. You can find professional consultants on how to deal with the most stressful parts of having typically developing children, how to deal with sleep, how to deal with feeding. There is not one manual on how to suction your kid on the side of a freeway or how to do an emergency trach change in a dirty public bathroom. And that is what parents of trach children need to know in order to bring their child home and have them there safely. If you're listening to me right now thinking, I don't know how I would deal with an emergency trach change in a dirty public bathroom, that is a very reasonable response. And it may be because you've never had occasion to go to a dirty public bathroom with any of your patients. But parents have. We have navigated trach emergencies in any situation you can imagine in all sorts of places. The information needs to be shared. But there are barriers standing in the way of effective sharing of information. Generally, we are isolated. We don't know other families. We don't have a platform other than social media with which to share the information. And most of us are overwhelmed. It's not a project that we have the bandwidth to deal with. And you can help facilitate the sharing of information. Families need a plan to successfully handle predictable emergencies. For trach families, many emergencies are predictable, like plugs, stoma occlusion, accidental decannulation, and everyone's favorite, your kid turns blue for some unknown reason. Trach families can prepare for predictable emergencies by having the right gear easily accessible, knowing how to escalate care yourself or call for help, and knowing how to prevent a crisis. So an example of how to prevent a crisis is having the right bag. The emergency bag is everything. It took me a decade to find this bag. This is a Cotopaxi bag brand. The top you can see is separated from the bottom. The far left picture is the bag closed, and the top is completely separate. So that is where I can put my emergency case, which is in the second picture to the right. You can see right through it. It's a hard case, and I can put my clean trach and my step down and everything that I would need for an emergency trach change right there. So when this is sitting on the back of my child's wheelchair, all I need to do is put my hand over, unzip, and I've got it right at my fingertips. I can do it with one hand. If you open it up, it opens all the way, and you can see through the mesh for very easily handling. And then I keep the ambu bag in what is actually just a regular packing cube that you can get on Amazon, and I put it off the chair. Emergencies will happen. This is a picture of my children just moments after a particularly unfortunate emergency trach change in a very disgusting public bathroom in the Pittsburgh airport. This is after I have thrown away my son's t-shirt, which was not getting on the plane, and before I ran down to Hudson News to get him an overpriced new one. And I think the expression on my daughter's face says it all. Emergencies will happen. They are terrible in the moment. You can get through them, but parents really need help thinking through what they're going to be experiencing, and you can help them do that. It took me a decade to be able to brush this one off, but you can help it happen faster.
Thank you, Nicole, for sharing your perspectives as a mother caring for a child with a tracheostomy in the community. It's just mind-blowing to realize how many of the things that most parents take for granted require thoughtful planning to prevent adverse outcomes for children with a tracheostomy. And I love your advice. Any plan is better than no plan. And your suggestion of emergency bag is brilliant. And reading through the comments here, it sounds like it resonates with many who are listening today. And I'm sure new parents of children with a tracheostomy will really appreciate your wisdom. I would also assume that each individual or family may find different supplies that are important for them to include in the bag, and also depending on what activity they're getting ready to do. So I would assume that most families will customize those bags to be as prepared and planned for any of these emergencies that may happen. So thank you again. I know Amy will be asking some questions from the audience, but maybe I'll just kick off with one question to you, Nicole. What are some of the common challenges or barriers that tracheostomy families face or may face when advocating for their child's safety needs within the healthcare system?
I think a common barrier is not being listened to. I think that it is hard. People of all walks of life, all education levels, all levels of, I suppose, readiness, have tracheostomies and tracheostomy family members. And I think that it does pay for doctors and other hospital staff to remember when they're encountering a parent or family member coming in, that this is the person that will be saving their patient at 3 o'clock in the morning. So, so you really should listen and try to have a good rapport with the family member, because that's who's going to be there when you're not.
Mm-hmm. Thank you, Nicole. I think you really said it. That is one thing we often overlook, even though, as Professor Warlow was saying, that we come in with good intentions, but sometimes we get into the weeds of getting the tasks done, that we truly overlook that aspect of listening to patients and family members. I wonder, Stephen, if you can share from your experiences, what are some of the most overlooked factors that can lead to complications in tracheostomy patients? Maybe you can build on what Nicole just shared.
Yeah, thanks, Vincia. I think there's nothing more compelling than the voice of a patient or a carer to remind us in healthcare that I think we take pride in knowing what we're doing, and I think we've got a lot of expertise and experience, but there's no substitute for listening to families and patients. So thoroughly endorse everything that Nicole has shared. The things that are most overlooked, it's the trivial things. It's the unexpected, the minor issue. I think when I'm putting the tracheostomy myself and I'm performing a tracheostomy, I've got a very heightened sense of safety and doing everything absolutely right. And that's as it should be. Similarly, if I'm doing a tracheostomy tube change, I have everything just right, and I do it the same way every time with the highest attention to safety. Where things can come unstuck is moving a patient from a bed to a chair, which seems like the most trivial thing in the world, but that's when you suddenly realize the trachea tube is in the patient's lap and the patient is not looking or feeling very good. And that's, I think, where we get caught out. Not when we see a recognized obvious crisis or undertaking what is an obviously high-risk procedure. It's a sunny day and on an average Tuesday afternoon, everything's fine, nothing sort of expected to be wrong, and then you're caught out. through lack of preparation. You're doing a patient transfer from chair to bed or similar, the tube's on the floor, and you haven't got the gear in the room to put it back in because it didn't feel like it was a big deal. So I think, and I think Nicole has given us a really important insight, is just the eternal vigilance that is required. Families obviously know this. And I don't think healthcare workers or senior clinicians ignore it, but our perception of risk is often for what we see as the highest risk periods, where, those are where things usually don't go wrong because we're really, really paying attention. So I think it's that constant preparedness, having the gear in the room, having done the simulation. Fortunately, and acknowledging everything Nicole said about problems being common, the crisis in acute healthcare with the tracheostomy is relatively rare, and many people will go for a long time without seeing one. And that's where things like simulation can also be incredibly useful. If the only practice I got from managing a major airway hemorrhage was in an actual major airway hemorrhage, then that's not great. That'll be very uncommon for me. Whereas I can practice it a couple of times a year and ensure that I'm maintaining my skill set and the teamwork works. So yeah, I think simulation for managing rare catastrophic disasters, but also constant vigilance that there is no minor issue when you're managing someone with complex upper airway requirements.
Thanks for that. And to all our speakers about your powerful talks, I think the common theme that really resonated were the concepts of team and culture, asking and listening, and those aspects of risk, the actual risk happening, and that concept of near miss, what could happen. In terms of optimizing how we foster that stronger team culture and that inclusivity, what would you say in your experience and wisdom would be sort of the top facilitators that have enabled that culture of including all team members being able to have those pauses and opportunities to ask and those moments to listen? I'm just keen to know what you think are the some top things that you'll be willing to share from your experience to pass on to the audience. Do you want to go first, Stephen? You're off mute.
I feel like I've already talked too much, but I think we know a bad culture when we experience it. I think a good culture, I've described some of the attributes in my presentation. I think recognizing that it doesn't just have to be the senior doctors that do all the talking. The best teams, I think, are genuinely multidisciplinary, not just including people from different backgrounds in the team, but recognizing their expertise and their contribution, and that it shouldn't be just the doctors in charge. I think we've thankfully moved a long way from that in the last 20 years. And some of the mentors and teachers that I have benefited from most have been senior experienced nursing colleagues, senior experienced speech therapists and physiotherapists or physical therapists, as they're referred to in the States, have taught me an enormous amount. And I think nudging our culture in such a way that is recognized and enhanced and promoted is very important. And every time I've seen people do that well, inevitably everything gets better. If you can achieve that. I recognize it's a bit of inertia sometimes in many of our systems, and there's a lot of traditional expectations and hierarchical arrangements, and these things take time, but it's worth the effort. But I think that the most durable benefits come from an evolution rather than a revolution. You just kind of kick it along, nudge it along, relentlessly push it, and genuine, durable, beneficial change will occur.
Thanks for those insights. Christina, what would be your sort of top tips to facilitate that team?
I actually would mirror everything that was just said. I think the multidisciplinary approach, where every discipline really offers such a unique perspective. I cannot offer what a speech pathologist can offer. I can't offer what a surgeon can offer, but I can offer a nursing's perspective. And I think if you can develop a team that honors and respects all the disciplines, and we respect the family's perspective as well, because each family is going to have a different home life. They're going to come in with different expertise. Some There's been some families who is one of the parents is a nurse or a physician. And so they come from a different aspect than somebody else who might be in business. So you have to meet the family at what their needs and what their levels are. And the team approach that has been at least developed throughout, I agree, decades at our institution too, where we have a multidisciplinary program, just a level of respect that everybody comes to the table with to benefit the patient. We all are there advocating for that family and for that patient. And if we can pool all of our resources together, that family and that patient are going to be the healthiest they can be.
And Nicole, just reflecting on your sort of top facilitators and drawing in one of the comments I've seen the Q&A just in regards to your top tips about having that space to be able to ask questions, to be able to listen, in that concept of that arc and that pathway that you mentioned in regards to living.
Well, I guess one thing I suppose I would say to this group is that, when you are, in terms of safety, when you are leaving the hospital for the first time, you've only been trained to deal with emergencies in a very controlled environment, at a bedside in a hospital where there are people down the hall to come in and save you. And the reality is that your patients' families are going to actually need to bag their child in the back of a car seat or at the frozen food aisle in the grocery store. And so letting them know that they can do it, if they can do it at bedside, they can do it in a safe way. They really can. But the scary part is not knowing what that looks like and never having been there and not knowing anyone who's ever done that before. So just really talking through this and I mean, I hate to say this because it's not normal, but normalizing it for someone who is going to be walking out for the first time really would go so far to making this in an easier re-entry into the world for those families.
And just sort of reflecting on what you're saying as well, and what came out in your talk is that importance of ongoing connection and ongoing, aligned to be able to ask those questions to people that may have experienced those new things or getting other sort of insights and help and tips. So that's an important thing about thinking about that ongoing connection and support as you continue to navigate the journey. Yeah, okay. I'm mindful of time and in terms of the webinar, just acknowledging there are a couple of questions I know still in the Q&A, so we will answer those. It may not be now, but offline we'll make sure that those responses are given to you. I wanted to, before I thank the presenters, I wanted to just give a shout out for our next webinar, which is coming up. That is going to be Friday, the 2nd of May. I'll make sure that's correct. So in your diaries, but it will be coming up in May the 2nd. So to find out more, please look at our website, globaltrach.org, but information will come out. I just wanted to thank the panel again for their time, their knowledge, their wisdom, sharing their insights, not only their time today, but in preparation for this. So I'd like to thank all the panelists for that. And again, the support of Dr. Pandian and Dr. Brenner for their support in leading the GTC. As Vincia said, it's a community, and there's a whole community of education committee that helps find speakers, identify topics. So I would like to acknowledge them. So with that, enjoy your day if you're starting, enjoy the day if you're ending it. So thank you for your time and joining us.
Thank you, everyone.